Now, the abdominal approach, the open abdominal approach, historically has been the most common means for performing fundoplication, particularly in patients who have uncomplicated gastroesophageal reflux disease. It gives you access to other intra-abdominal pathology. Compared with a thoracotomy incision, you got reduced levels of initial postoperative pain. You have better operation in patients who have pulmonary insufficiency, and for patients who are relatively old. The downside is that there is an appreciable incidence of incisional hernia. For that reason, the laparoscopic approach has become now, I think, the favored approach for patients who have straightforward gastroesophageal reflux disease and require fundoplication. It's the least painful of the three different approaches that can be used. It, too, gives access to other intra-abdominal pathology. It's much more useful than open laparotomy in patients with pulmonary insufficiency. The downside of it is that in some surgeons' hands, the operation is not identical to that performed through an open approach. And for that reason, we have lack confidence in the long-term results in these patients. There are a lot of people who are doing laparoscopic fundoplication who had little experience with open fundoplication, and that is worrisome. On the other hand, I have a reasonable degree of confidence in surgeons who have a lot of experience with open fundoplication who are now doing it laparoscopically, because I have seen their videos and so on and know that they're using an identical technique to that used with the open approach. Now, the thoracic approach is one that I still favor, but there are specific indications for using a transthoracic approach as listed here. One, it's good for patients who have suspected other intrathoracic pathology. I think it's quite useful in patients who are obese. It makes the operation very simple. You avoid all of that hassle of going through a very thick paniculus. There is almost a zero incidence of wound infection in these patients. And if you have complications of gastroesophageal reflux disease, it's quite important to consider this approach. The types of complications I'm thinking about are severe stricturing, previous surgery for gastroesophageal reflux, and, of course, shortening of the esophagus would be an important indication for a thoracic approach. There have been a couple of reports of a thoracoscopic fundoplication technique. The ones that I've seen are very unsatisfactory, and I don't think this is an acceptable technique to use currently. Now, in terms of the total versus partial fundoplication, the total fundoplication is by far the most common technique that's used. It yields the highest lower esophageal sphincter pressure, and by virtue of that gives the best overall control of gastroesophageal reflux. The downside of that is that there's a higher incidence of initial postoperative dysphagia in these patients, and in some patients there will be development of the so-called gas bloat syndrome. These patients have a combination of inability to belch and chronic air swallowing, leading to large volumes of gas collecting in their stomachs, and it's quite uncomfortable. The other problem that's fortunately uncommon in the patients is so-called slipped wrap syndrome, in which some of the stomach herniates up through the wrap, creating an iatrogenic paraesophageal hernia, which is quite problematic because they have acid trapping above the wrap and very extensive exposure of the esophagus to acid. So the most common total fundoplication, of course, is the Nissen fundoplication. Now, the partial fundoplication, I think, is particularly useful in patients who have an underlying non-specific esophageal motility disorder. And that can be documented either by poor esophageal clearance on 24-hour pH monitoring or by formal manometric testing in these patients. It creates a slightly lower esophageal sphincter pressure. These are typically very effective for control of acid reflux, perhaps not quite as effective as the total fundoplication, but still very satisfactory. The main advantage, of course, is that you don't have dysphagia typically in these patients post-operatively, and there's complete absence of gas bloat syndrome. All these patients are able to belch and to vomit relatively normally. The most common partial fundoplications performed now are the Belzy for the thoracic approach, and the name is escaping me now. Toupee, yeah, thank you, for the the laparoscopic approach. Now, in terms of specific complications of reflux that require surgical intervention, the most common is probably a peptic esophageal stricture. The strictures, of course, arise at the squamocolumnar junction. Sometimes that junction will be up in the chest, as illustrated here. Most often it will be on a relatively normal location. And it's important to evaluate these patients preoperatively. So biopsies would be used to rule out the existence of underlying carcinoma misdiagnosed as a peptic stricture. Dilation is important to do in these patients preoperatively so that you make sure the stricture is dilatable before you get into the operation, because the inability to dilate a peptic stricture preoperatively would change your operative approach quite dramatically. Be prepared then to do an intraoperative dilation. You should be able to get the patients up to at least a 50 and hopefully a 60 French intraoperatively, and then to perform a fundoplication. Now, in some instances, if the stricture is non-dilatable, one of the options is to do a fundic patch, a so-called thal patch, opening the stricture up and closing the stomach over it as an esophagoplasty. Generally speaking, the results of that are not very satisfactory, and so as opposed to doing a patch for a non-dilatable stricture these days, I will most often do an esophagectomy, but it's rare that for a garden variety peptic stricture, esophageal resection is necessary as long as careful preoperative planning and progressive dilation is performed before the operation. In terms of medical therapy for peptic stricture, it's not too bad. You can see about an 80% long-term success rate with a perforation rate of about 1 or 2%. So what we're talking about is operating on maybe 10% up to 15, maximum of 20% of patients with a peptic esophageal stricture. Standard fundoplication for these patients has a very good success. We think of the success for standard fundoplication without strictures being a success rate of about 85 or 90%, and so for patients with stricture, the success rate is going to be about 80%, slightly less, but still very acceptable. And then there's also a small group of surgeons who have reported results of diversion, acid suppression and alkaline diversion for management of stricture problems. This concept was really originated by Henry Ellis when he was at Mayo Clinic, and is so done now at the Mayo Clinic, at the Leahy Clinic, and occasionally in some European centers. And you can see with those surgeons who have extensive experience with this, the results are fairly good, but the numbers are quite small. And it's a large operation, antrectomy, Roux-en-Y diversion of the biliary output. And so I don't recommend this as a standard therapy for reflux problems, but as a consideration in patients who perhaps are on their second or third reoperation for reflux problems. Now, in some cases, there will be esophageal shortening associated with the stricture, and this is often accompanied by severe mediastinal fibrosis because of transmural inflammation of the esophagus. So you can see the gastric funduses, or the gastroesophageal junction, has been pulled way up into the chest here with the stricture up at this level here. Now, this requires a little bit more thought to take care of, and you do the usual preoperative evaluation and dilation. Dilation is very important in these patients preoperatively because some people believe, at least, I'm one of them, that you can provide some esophageal mobilization or lengthening if you do successive dilations, forcing those dilators down through this relatively tight stricture. When the operation is performed, it should always be performed transthoracically as opposed to transabdominally or laparoscopically, because extensive mobilization of the esophagus is quite important. Usually mobilizing the esophagus up to the level of the aortic arch is not usually feasible through the abdomen. Now, if you can sufficient mobilization of the esophagus so that you have a normal intra-abdominal length of esophagus and do a tension-free fundoplication, then that's fine. You'll get very good results. If you can't achieve that, then the choices are to perform an intrathoracic fundoplication, which I would recommend you not do because of catastrophic complications that have been reported with a relatively high frequency. So the two choices really are to do an esophageal lengthening procedure, a esophagoplasty, or esophageal replacement operation, resection and reconstruction. In terms of lengthening procedures, the Colles-type gastroplasty combined with either partial or a total fundoplication have given pretty good results in the hands of experienced surgeons, 80 to 85% success rate, and the mortality rate is quite acceptable. So this should not be too much different in terms of morbidity or mortality or outcome from a standard fundoplication. You're all familiar with how to do a Colles gastroplasty? Anybody not? And the other option is to resect these patients, and this should be held as a last resort because of the associated relatively high mortality rate and relatively poor long-term outcome based on still a relatively large number of patients. So any questions about management of suture problems? Esophageal ulceration is fortunately quite uncommon. Ulcers can develop in esophagitis lying within the squamous mucosa. These are typically quite superficial and almost always will heal with conservative therapy. The type of ulcer illustrated here is a Barrett's ulcer, and these ulcers are quite different than the typical ulcer in the squamous mucosa. These are more similar to gastric ulcers, and they can be quite deep and penetrating. And 10 years ago or so, before we had very good acid suppression therapy, these required operations at the time to provide healing. Nowadays, with omeprazole or with an high-dose H2 receptor blocker therapy, these will heal at 80% of the time and not recur. So it's the non-healing ulcers then that require surgical intervention. Once you've ruled out the existence of carcinoma, the operation is done transthoracically once again because it's important to determine the depth of the ulceration. If it's penetrated into the mediastinum, then resection is necessary combined with reconstruction. And be sure if you're going to resect Barrett's ulcer that you resect all of the Barrett's mucosa at the same time because otherwise you'll get recurrent reflux disease and ulceration as has happened in patients referred to me on more than one occasion. The standard operation, if the ulcer is contained within the esophagus, is fundoplication, and this will permit healing the ulcer in the vast majority of patients, and usually accompany that with intensive acid suppression for a period of a month or two post-operatively. Now, in terms of results, standard fundoplication techniques, we would expect 80% of patients to have good, excellent results, another 15% of patients to have fair results. So this is our 85-90% acceptable outcome for fundoplication. And then about 5% of patients will be unchanged and unfortunately worse as a result of surgery. It's interesting to look at the comparison between the partial fundoplication and total fundoplication. The overall results are about the same for these patients. And we get a similar outcome in terms of poor results as well. And if you look at the symptoms that patients have postoperatively, they're quite different, however. So you have a lot more heartburn in patients who have a partial fundoplication compared to total fundoplication. But in patients with total fundoplication, you'll have a much higher incidence of dysphagia or chest pain. There's a trade-off here, as I've mentioned before. Interestingly, if you ask the patients how they think they did with the operation, their evaluation comes out very similar to the surgeon's evaluation and to the so-called objective evaluation, looking at the anatomy of the repair and the results of pH study. So about 90% are satisfied with the operation and have the operation again. So once again, this is a pretty good operation to do for a very common disease process. Now the downside is that the results of surgery tend to deteriorate over time. And some of this is due to breakdown in the repair, some of it's due to patients gaining weight, a poor decrease in the esophageal motility, and so on. But if you track patients over a number of years, where if you start out about 85%, you're going to wind up about 70 or 75% 15 years out. It's something that you and the patients need to be aware of, and as a reason to do long-term follow-up in these patients in some setting, either the gastroenterologist or in the surgeon's office. Now, if you have a failed fundoplication, if the cause of fundoplication failure can be quite varied, and an intensive evaluation is often necessary in these patients. There can be technical problems, such as the wrap was performed too tightly, or the wrap slipped or broke apart. In the old days, we see a lot of patients who had crural repair without a fundoplication, but called an anti-reflux operation. Rarely worked. In some patients, there was a misdiagnosis preoperatively, and in fact, they had a motility disorder. It was diagnosed as a reflux problem. You can imagine what sort of symptoms they had after you had a wrap on to an underlying motility problem. Vagal nerve injury will lead to slowing gastric emptying, which can promote reflux problems. Rarely, fortunately, we'll have fistula formation. This is most commonly associated with placement of angel chick prostheses, and we've taken out a lot of prostheses for problems like that. And in some instances, we're generally pessimists as surgeons. When something goes wrong, we tend to blame ourselves, but sometimes the patient's symptoms are due to something brand new, and so an intensive evaluation is appropriate. Now, when we finish an evaluation, you'll find that some patients will have loss of sphincter competence, so a problem primarily with the LES. Some patients will have poor esophageal clearance, so a problem with the body of the esophagus itself. About half patients will have a combined failure of LES function and of esophageal body function, so general deterioration in all of these tissues. Rarely you're going to have alkaline reflux as a problem, and then these others, of course, are misdiagnoses and new disorders of other organs. So the evaluation should include barium swallow, endoscopy, gastric emptying scan, motility tracing, and pH study in order to achieve an adequate and accurate diagnosis in the patients. There are certain risks of failure for fundoplication. Surgeons' inexperience is probably the most common cause for failure, but patients' obesity or development of obesity postoperatively certainly contribute. If there is esophageal shortening, the results of surgery are less good than without esophageal shortening. And advanced age is clearly correlated with a loss of effectiveness of fundoplication. Now, if you determine that a patient has failed fundoplication, what do you do about it? Fortunately, most of the patients don't require reoperation but can undergo intensive medical therapy with relatively good outcome. Occasionally, redo fundoplication is necessary. The most common indication for refundoplication, at least in my practice, is slipped Nissen with herniation of the stomach up through the wrap. And that's a relatively urgent indication because these patients can develop quite severe esophagitis. Occasionally, if there's anticipated great difficulty in doing a redo fundoplication, then the alkaline diversion acid suppression operation that I mentioned before is appropriate to consider. That would be preferable in many patients to resection, resection being the course of last resort in patients who cannot undergo any of the redo operations I've mentioned above. So any other questions about gastroesophageal reflux disease or surgery for it before we move on? Yes?
In the complications of the transabdominal approach, the slide said 5 to 10% incidence of hiatal hernia, and you said incisional hernia.
If it's a typo, it should be incisional hernia. Yes?
Constitution, laparoscopic fundoplication is entirely in the province of the general surgical service. Is that a combination why you perceive that to be a long-term trend? Surgery for esophageal reflux is the first time patient going to essentially go back to the general surgeon.
Well, they're going to go to the surgeon who's doing the kind of operation that the medical people are interested in. If you have a pure thoracic practice and are unskilled in laparoscopy, then it's likely they're going to go to the general surgeons. It's necessary for a pure thoracic surgeon to develop laparoscopic skills and to demonstrate those to the gastroenterologist to maintain that referral pattern. So the ways of doing that are to do laparoscopic staging or initial evaluation of patients with esophageal cancer, junctional cancer, for example. But we're at a real disadvantage because the gastroenterologists have typically a much closer connection to general surgeons than they do to thoracic surgeons, and they perceive the general surgeons as being laparoscopists. It's an uphill battle, and I think the trend is away from thoracic surgeons doing the fundoplications. Yeah. Other questions?
Sir?
Yeah.
Do you try to dissuade your medical gastroenterologist from treating strictures, since you continue to treat strictures with dilatation and any medical management, all you're going to do is get a pan esophagitis?
Well, I don't agree with that. First of all, the initial stricture management is generally the province of the gastroenterologist. They're quite skilled at doing dilation by and large, and they know about intensive acid suppression. Just because you dilate a stricture doesn't mean that they're going to get panesophagitis. It can't be just dilation. It has to be combined with intensive acid suppression, which should prevent that from happening. And at least the literature says that about 80% of those patients will do well with that type of management. So there's not, you can't make a good argument for that, making that a surgical problem until they've demonstrated failure. So does that answer your question? I know you're not happy with the answer.
It just seems that you continue to dilate it because you have reflux.
So you have to have an ongoing communication with the gastroenterologist. Typically, continued dilation is not going to be necessary. Usually, one or two or perhaps three dilations are all that are necessary. Now, you will have continued reflux, but you don't necessarily have continued esophagitis if they have adequate acid suppression. Now, then we get into the discussion of how long are you going to do acid suppression before surgery becomes a viable alternative, and that has to do a lot with whether the patient's symptoms are controlled and the age of the patient and how long you anticipate acid suppression is going to be necessary.
Somebody with biopsy-proven Barrett's, is it necessary to get pH monitoring on those patients to prove that the cause of Barrett's is reflux?
Well, Barrett's and reflux are not synonymous. It's not always necessary to prove that there's reflux to prove the etiology of the Barrett's. Most people think that Barrett's is etiologically related to reflux. I think finding Barrett's is probably about the same as finding esophagitis. And so I don't think you have to do pH monitoring to further assess the patient. I think most of those patients require some acid suppression as sort of empirical therapy. Most of them will have a history of heartburn at least. The development of Barrett's oftentimes eliminates to some extent the reflux symptoms patients have. But I think it would still be important to do acid suppression so that you can at least theoretically decrease the progression of the Barrett's. Other questions?
In the biopsy of Barrett's?
Well, we'll talk about Barrett's a little bit later. I'm sure we're going to go into that detail. The range of recommendations is from 6 months to 2 years, and there are some publications that suggest that an interval of 5 years is appropriate in terms of cost of effectiveness. I don't think the American public would settle for missing a small number of Barrett's adenocarcinomas by lengthening the interval to that extent. I personally do it every year, and I alternate endoscopic directed biopsies and blind brushing of cytology. Okay, let's move on to hiatus hernia very quickly. Just to review the anatomy with you briefly. The typical esophageal hiatus is illustrated here with the phrenoesophageal membrane illustrated here and the diaphragmatic crura, as you see. And anteriorly, the reflection of the peritoneum illustrated here. Now, when we have a typical sliding type hernia, the phrenoesophageal membrane continues to insert at least for a portion of the circumference of the gastroesophageal junction anteriorly, and there is a linear sliding of the stomach and gastroesophageal junction in line with the esophagus up into the mediastinum. So this is a type 1 esophageal hiatal hernia. The other types of hernia are called paraesophageal hernia. There is some misunderstanding in some people that this is through a different opening in the diaphragm than the esophageal hiatus was incorrect. It all comes through the esophageal hiatus. The paraesophageal type 2 hernia, illustrated here, has the gastroesophageal junction in a normal location within the abdomen and herniation with a true hernia sac of the gastric fundus alongside the esophagus. And then the type 3 hernia is also a paraesophageal hernia that's a combination of the types 1 and 2. So you have a sliding component in which the gastroesophageal junction has risen up into the mediastinum, and you also have the paraesophageal component as illustrated here. Now, in some publications, you'll see reference to a called type 4 hernia. This is not, in my mind, an official subdivision of the types of paraesophageal hernia. What it refers to is not the anatomy of herniation, but the contents of the hernia sac. And so in addition to gastric fundus, you also have some other intra-abdominal contents, most commonly the splenic flexure of the colon. The incidence of these hernia, both types 1 and paraesophageal hernia, increases with age and become more common in women in older age than they do in men in older age. And this is presumably some hormonal effect. The type 1 hernia is usually asymptomatic. If it does have symptoms, it's typically symptoms of gastroesophageal reflux problems. It's present in a substantial minority of patients with gastroesophageal reflux disease, and this includes patients with very small type 1 hernias. In types 2 and 3 hernias, these patients are frequently symptomatic, and the type of symptoms that they experience are early satiety, regurgitation, epigastric pain, and chest pain. There is an appreciable incidence of serious complications in these patients. Historically, some groups have been followed who are felt to be poor risk surgery had sufficiently minimal symptom that surgery was felt to be unwarranted, and 25% of the patients in one study developed catastrophic complications associated with their hernia, leading to mortality in most of those patients. Even though both of the types of hernias have an increasing incidence with age, types 2 and 3 hernias are more common in the older population than type 1 hernias. And most of the patients that I see with this problem, they're in their 70s or 80s. So the indications for surgery, patients with type 1 hernia would be the same as for those for gastroesophageal reflux disease. If they have indications for surgery for reflux problems, then repair of the hernia is appropriate at the time of operation. It simply consists of mobilization of the esophagus and then doing a standard fundoplication operation. Type 2 and 3 hernias, basically all paraesophageal hernias, should be repaired shortly after the diagnosis is made in patients who can tolerate a major operation. Either a thoracic or abdominal approach can be used. Some of these are now being done with a laparoscopic approach, and I think the initial reports are that it can be done satisfactorily that way. I have recently completed a comparison of a fairly large number of patients who had thoracic or abdominal approaches with or without additional fundoplication. It appears that there's no real difference whether or not you put a fundoplication on or whether or not you operate through the chest or the abdomen. So mostly surgeon's personal preference is important. So the principles of the operation are, of course, to excise the hernia sac in all patients and to do an appropriate approximation of the crura to close the potential space. And then anchoring the stomach down below the diaphragm is an important third element. So I typically will add fundoplication, usually a partial fundoplication, because this anchors the stomach and esophagus below the diaphragm very effectively. The other ways of anchoring the stomach are to do a gastrostomy or anterior gastropexy, and it's probably equally effective. One of the things that I find useful in the transthoracic approach is that I've had 1 or 2 patients who have had true esophageal shortening associated with the paraesophageal hernia, and it was useful to use that approach to do esophageal mobilization. The other thing is that you can dissect the right limb of the right crusoff of the pericardium rather extensively through the chest and get better mobilization of that to do a tension-free repair, tension-free closure of the esophageal hiatus, and that avoids the necessity to put prosthetic material in place if you have a huge opening and very attenuated tissues on either side of the opening. But aside from those caveats, I think either approach is appropriate, and they're all effective. They're effective in about 95% of patients. Are there any questions about treatment of hiatus hernia problems before we go on to motility?
These are type 2 large hernias. They are, even though the esophagus, gastroesophageal junction remains at the normal place, the fundus comes up. When you repair, the approximation of the crura is so much a problem. They always break apart, because of the thinning over a period of number of years.
Yes, it can be a problem. That's why it's important to do adequate mobilization of the diaphragmatic crura, which is possible from the chest. It's not really possible from the abdomen. If you have very attenuated tissues there and you're in the abdomen and you can't close things, then you have to put prosthetic material instead. So motility disorders we divide into 4 major categories. There are 3 primary esophageal motility disorders: achalasia, with which you're all familiar, diffuse esophageal spasm, and high-amplitude peristaltic tractions of the esophagus. And then the 4th and the major category of esophageal motility disorders is a grab bag of so-called non-specific esophageal motility disorders, or NEMD. We'll talk first about the general findings with motility disorders. Symptoms that are most prominent include dysphagia and chest pain, with regurgitation being distant third in frequency of symptoms. The standard technique for evaluating these patients is a motility study to make the diagnosis. And this is important when we do this to evaluate the upper esophageal sphincter, the esophageal body, and lower esophageal sphincter, because there are often interrelated disorders of these three different components of the esophagus. pH monitoring is sometimes useful, but doesn't contribute very much to the evaluation of what's suspected to be a motility disorder. Endoscopy should always be performed if the patient is experiencing dysphagia to make sure you eliminate the possibility of an obstructive lesion within the esophagus. And finally, a barium swallow is typically done, whether it's beneficial in the diagnosis or not of motility disorders like amplitude peristaltic contractions or diffuse esophageal spasm is debatable. It's quite useful for making a provisional diagnosis of achalasia, however. Now, in terms of achalasia, I think most of you are familiar with this, and I don't want to spend too much time on it. It's a progressive disorder, dysphagia beginning with solids and progressing to liquids. It has an insidious onset. Typically, the patient is not aware that there's a problem for several years after onset of symptoms. Common types of symptoms, in addition to dysphagia and regurgitation, include weight loss and, at least historically, aspiration with basilar fibrosis, lung abscess, or pneumonia. Fortunately, treatment is initiated much earlier in most patients in this country now than used to be the case, and the treatment's much more effective, so we don't have these more serious complications these days. Now, if you do endoscopy, you will almost always see stasis esophagitis, sometimes with a cobblestoning appearance, almost like Crohn's disease of the esophagus. The lower esophageal sphincter looks tight, but it's quite easy to push the endoscope through. And it's important to make that distinction because there is a appreciable incidence of pseudoachalasia caused by a tumor of the gastroesophageal junction, in which case you should not be able to easily pass the scope through, and that biopsy should be done if you find that it's hard to pass the scope down through. There is an increased risk of esophageal cancer, squamous cell carcinomas in these patients. It happens with increasing frequency generally after 20 or 30 years from the time of diagnosis. I think the overall incidence is about 10% in a patient's lifetime. And it's a sufficiently small incidence with a long interval between diagnosis and the development of a cancer, so that surveillance endoscopy, at least by the cost-benefit analyses that have been done so far, suggests that surveillance endoscopy is not useful for these patients. This is a typical radiographic picture showing esophageal dilation and air fluid level in the esophagus and the typical bird's beak deformity of the distal esophagus. So these three abnormalities would be suggest the diagnosis of achalasia on barium swallow. This is the same patient 1 year later showing increased dilation of the esophagus, and these patients will have progressive dilation in the absence of successful therapy over a period of years and years, which can eventually lead to a sigmoid type esophagus like this. Now, the diagnosis is made manometrically. At least in the U.S., manometry is the gold standard for diagnosing achalasia, and at least the gastroenterologists that I work with will not do therapy for achalasia until motility has been done to confirm the diagnosis. There are 5 primary findings in manometric findings in achalasia. The 2 most important ones are absence of peristalsis in the distal esophagus and failure of complete relaxation of the lower esophageal sphincter with deglutition. And then there are 3 sort of minor findings that we see: an elevation of the resting pressure of the body of the esophagus, sometimes high simultaneous high amplitude simultaneous contractions with when the body is the esophagus, and not infrequently an elevated resting pressure of the lower esophageal sphincter. Let me just back up 1 second and say that when we're talking about these high-amplitude simultaneous contractions, these are referred to as vigorous achalasia, and I've found in about 10% of achalatic people, and generally are seen early on in the course of the disease and tend to diminish with time. Now, the pharmacologic management of achalasia is generally unsuccessful. If you have somebody you need to tide over for a short period of time, or somebody who's too sick even to have an esophageal dilation, then a smooth muscle relaxant such as nifedipine has been shown to statistically lead to a decrease in lower esophageal sphincter pressure and an improvement in esophageal emptying. Unfortunately, those objective improvements are not correlated with improvements in symptoms. And if there is symptomatic improvement, it generally persists only for a period of 4 or 6 weeks. So pharmacologic management with smooth muscle relaxants is not generally used. Now, what's new on the horizon is the injection of botulinum toxin at the lower esophageal sphincter, and the initial reports of that are that it is quite successful. As with esophageal dilation, there's very little long-term follow-up of these patients. We don't know how they're doing 3 and 5 years down the line, but certainly for the first year or 2 following injection, there's probably an 80 or 90% response rate. So this is something that's becoming increasingly popular in the United States, and it's been used in Europe for a little bit longer period of time. But the standard techniques for treatment of achalasia now are pneumatic dilation and myotomy. In terms of pneumatic dilation, we can expect by the gastroenterologist criteria improvement in about 80 to 90% of patients now. Good document objective improvement is probably more accurately assessed at about 75–80% of patients. That's the number that my colleagues and I quote to patients who are considering one type of therapy or the other. The perforation rate should be in the range of 2 or 3%, and the need for early operation in patients who fail pneumatic dilation should be in the range of 5–10%, I think. This is quite successful therapy, and if you work in a community or an institution in which there is a gastroenterologist or a surgeon who's skilled at doing pneumatic dilations, this is the preferred initial therapy, in my opinion, for most patients at the present time, primarily because it's relatively successful and it's very inexpensive. However, it's not good for long term, and so these patients need to be followed. If you look at the need for additional therapy over time, this is repeat pneumatic dilation, and this is a group of patients who have either repeat pneumatic dilation or esophageal myotomy. As you get up to 5 years, about 40% of patients are going to need some other type of therapy. So while the pneumatic dilation is good and inexpensive, it doesn't necessarily last as long as one would wish. And also, if you look at the first episode of dilation, this is subsequent dilations after an initial successful dilation, you can see that additional therapy is necessary, once again, in about 40% of patients at 5 years who have had one dilation. But the second and third dilations are much less successful, and additional therapy such as surgery is useful, is needed in the majority of those patients a number of years later. So my recommendations generally for initial management of achalasia are to do a dilation, see how it works. If that doesn't provide satisfactory relief, or if the patients develop symptoms subsequently, then I would recommend an operation to them as opposed to another episode of dilation. Now, in terms of operation for achalasia, there's a lot of things happening in terms of laparoscopic approaches, thoracoscopic approaches, and so on. And I'm not going to go into great detail on those because there aren't very many data that one could use to substantiate conclusions or recommendations. But we'll talk generally about approaches and so on. It will incorporate those techniques. First of all, we compare the historic experience in Europe and the U.S. The U.S. has long been a thoracic approach for esophageal, for operation for achalasia, whereas Europe has traditionally been an open abdominal approach. And that is translated now into, in the U.S., more commonly thoracoscopic approaches versus laparoscopic approaches, whereas in Europe they're using laparoscopy much more often. Having the same problem now with management of achalasia as we do with gastroesophageal reflux disease, as more of these patients are being referred to general surgeons as opposed to thoracic surgeons. It's becoming more common for them to a thoracic, a laparoscopic myotomy and they have very little experience with standard open myotomies, unfortunately. Now, when we look at the proximal extent of myotomy, there's very little data that suggests an extended myotomy is mandatory to do. If you have a patient with vigorous achalasia, it would probably be helpful to decrease symptoms of those patients by extending your myotomy up to the level of the inferior pulmonary vein. What's more controversial is the distal extent of myotomy. There are basically two schools of thoughts as to the distal extent. One is the school that, once again, was the main proponent of which has been Henry Ellis, both at Mayo and the Leahy Clinic, and this is to do the myotomy to the distal end of the lower esophageal sphincter and not onto the stomach, and that's all that's necessary. And in my experience, that landmark is a very difficult one to identify. So unless you've been trained by one of the few individuals that's quite skilled in this, you're going to find that you're going to have a high incidence of incomplete myotomy, or maybe I should say or a high incidence of postoperative gastroesophageal reflux. And so the other school of thought is to extend the myotomy well on the stomach for 1 centimeter or 2, and then routinely do a low-pressure fundoplication to prevent reflux. And I would say most of the centers in the U.S. are doing this combined approach. So the patient have very little dysphagia postoperatively, but also have a very low and acceptable level of gastroesophageal reflux. And the centers who have extensive experience, the results of the two types of operations are identical. So there's no way of demonstrating by way of data that one is superior to the other, and there are no controlled randomized studies in a single center that would provide comparison between the two. The minimally invasive techniques should provide the same outcome if the operation is done identically. Unfortunately, the people who were doing open thoracotomy, myotomy and fundoplication, now doing thoracoscopic myotomy without fundoplication. So we'll have to see what the long-term results of those patients are going to be. What I would caution you about is doing an operation through the abdomen and not adding a fundoplication. The overall results of myotomy with or without fundoplication should be in the range of 90+%. Good or excellent outcome with an extremely low mortality and a relative 5 to 10% rate of gastroesophageal reflux, generally requiring only medical therapy. Now, if you look at the abdominal approach with fundoplication versus without, and compare that to thoracic with and without fundoplication, you see the only one that falls out as having unacceptable outcomes is the abdominal approach without fundoplication. And this is because almost always the abdominal approach cut through and onto the stomach, thereby destroying much of the anti-reflux mechanism. And I think it's important in those patients to add a fundoplication, a low-pressure fundoplication, and then toupee is the one that's most commonly used in those patients. These are the results of the minimally invasive approach, most done abdominally, a couple of reports from thoracoscopic approaches. And the results are similar in very, very short term to the long-term follow-up of the open approaches. It's interesting that in Carlos Pellegrini's study, he actually did esophageal pH monitoring in almost all of his patients postoperatively, and is documenting about a 10% incidence of pathologic reflux in these patients, whereas their relative symptom level is low. Their scores are quite high. The rest of these symptomatic reports without objective evaluation postoperatively. So that's something that we're going to keep an eye on, is whether reflux is going to develop in these patients and what the completeness of the myotomy is. So we'll move on from there to diffuse esophageal spasm. Most of you know diffuse esophageal spasm as a disorder associated with dysphagia, but also primarily associated with chest pain. The chest pain is quite distinctive in nature. It's associated with periods of stress, and these patients are frequently a little nutty and not at all fun to take care of. Also, hot and cold foods can precipitate episodes of chest pain. When you evaluate the patients endoscopically, everything is completely normal unless they're having episodes of diffuse spasm at the time, and then you'll see some segmenting contractions within the esophagus. Manometry is the means of diagnosing these patients. What you need are prolonged contractions in excess of 10 seconds, and this has to affect more than 30% of the wet swallows. You also see sometimes an elevated amplitude of these contractions, but that's not necessary for diagnosis. The management of these patients is smooth muscle relaxants, and it's successful in about 3/4 of patients. And in the if there's failure of management with smooth muscle relaxants, myotomy is performed. And this can be done thoracoscopically or with an open thoracic approach. It's not clear about the distal extent of the myotomy or need for fundoplication, and that's something that's not addressed in the literature and people have very personal feelings about. Let me just end up then by talking about high amplitude peristaltic contractions of the esophagus, the final primary esophageal motility disorder. This is associated with very prominent angina-like pain. These patients rarely have any dysphagia or any other esophageal symptomatology at all. The vast majority of them are evaluated by cardiologists or actually admitted through the emergency room coronary care unit as the means for first identifying the presence of this problem. When you do the barium swallow, it's completely normal. And when you do an endoscopy, it's completely normal. So the only way that you can make the diagnosis of these patients is by doing manometry. And what you see in manometry is in the distal 5 centimeters of the esophagus, exceedingly high contractions of the esophagus that are peristaltic in nature, but very high amplitude. They have to exceed, on average, more than 200 millimeters of mercury, and frequently you'll see them in the range of 300 to 350 millimeters as illustrated here. The treatment for these patients by and large is smooth muscle relaxants. Rarely myotomy has been reported as being necessary because of the failure of medical therapy. And the only reason that we address this is because we are seeing patients with chest pain as part of the differential diagnosis of chest pain, and you have to know it also as one of the primary motility disorders.
So we'll start off with surgery for TB and fungal disease with a little epidemiology. Between 1953 and 1984, the number of cases of TB, and this is CDC data out of Atlanta, number of cases reported decreased by about 5.6% per year, from some 84,000 in the mid-50s to 22,255 in '84. But unfortunately, like many other communicable diseases, between 85 and 93, the number of cases started to increase again. and the actual increase reported was 14%, so that in 1993 there were 25,000 cases reported in the United States. And I think that number is still increasing. I don't have further data from the CDC. It's not published yet, but I expect that the numbers will continue to increase with the coexisting diseases like HIV, for example. It's estimated that between 10 and 15 million people in the United States are infected with TB. Approximately 10% of those will go on to develop tuberculosis disease. A little bit on medical therapies to put it into perspective. Current recommendations are that patients newly diagnosed with TB be put on 4-drug therapy, including INH, rifampin, PZA, and either ethambutol or streptomycin until the susceptibility is known. And you know that it takes 6 to 8 weeks of culture before you know susceptibilities. If susceptible to the first 3 drugs, the others be dropped off. And in HIV-negative patients, INH and rifampin for 6 months is the current recommendation, with PZA for the first 2 months. In HIV-positive patients, the same regimen is advocated for a minimum of 9 months, or at least 6 months after the sputum becomes negative. So now, after that brief sojourn into medical therapy, we'll talk about the indication for surgery in tuberculosis. And we'll go over them in sequence, starting with destroyed lung with persistently positive sputum. Then talk about indications for surgery in TB when you want to rule out malignancy in a residual mass or infiltrate. For massive hemoptysis, we'll go into that in some detail. For bronchopleural fistula with chronic empyema, usually related to rupture of tuberculous granulomatous cavity into the pleural space. For bronchial stenosis, for trapped lung with residual space, and for complications of plombage therapy, which is a therapy in the used in the 40s and 50s in order to treat TB by collapse type therapy, or one of the methods of trying to obliterate residual spaces. In destroyed lung with persistently positive sputum, you'll find that these patients usually have atypical mycobacterium. Lobectomy will be the most commonly required operation. Always consider covering the bronchial sump when you have persistent positive cultures in order to minimize the risk of developing a bronchopleural fistula in the post-operative period. You'll find that in most reported series, which are small in number, there is about an 80% successful outcome reported. In those cases where you have a residual mass or infiltrate and you suspect a coexisting malignant condition, a change in the size or shape of that mass might provoke you to contemplate surgery for it. Failure of an infiltrate to resolve despite compliance with therapy, and properly administered TB therapy, the most effective way of administering it is by directly observing the patient taking the medications. The diagnosis in these cases, unfortunately, of coexisting malignancy is usually made late, because you're always hopeful that the residual mass or infiltrate will resolve, or you're hopeful that it just represents scarring from the process itself and not coexisting carcinoma. Surgery is certainly indicated for diagnosis in suspected cases, and pulmonary resection, of course, for treatment once the diagnosis has been established. Now, what about massive hemoptysis? I think that this might evolve as the most common indication for surgery in the face of TB. It's been variously defined, and I've chosen one of the more common definitions of 600 cc's of blood coughed up within a 24-hour period. Some people would consider a lesser amount in a short time frame, like an hour and a half or 2 hours in the emergency room, rather a massive hemoptysis episode, and that I would not argue with. The source is almost always bronchial arteries, systemic circulation. less commonly from a pulmonary artery, and least commonly from an extrapulmonary systemic artery. It's due to TB complicated by aspergillosis in about 50% of cases, or at least aspergillosis is found to be a saprophytic colonizing organism in at least 50% of cases where resection is performed. Just to review for you the common bronchial artery anatomy, and this is views from the back, looking at the patient's descending aorta from the back. About 40% of time you'll have an intercostal brachial artery, for the second intercostal brachial giving a single right bronchial artery that then bifurcates, and two left-sided bronchial arteries come off separately from the aorta. In about 21% of cases, you'll find the two situation with a single right, again coming off the second intercostal brachial, and a single left. Less commonly, find these scenarios with a single right, two rights, one coming off intercostal brachial and one coming off the aorta separately, and two lefts. Or in type 4, two rights and one left. There are other combinations which are even less common than 9.7%, as illustrated in this particular series. Now, what is the initial management? Well, this is initial and really ER management, and if I had my preference, I would always want to know about these patients that they hit the door of the ER. Unfortunately, it doesn't always happen that way, and you're called sort of in the middle of the night when they're decompensating in an intensive care unit or on a ward somewhere. But the initial management should be bed rest, with either a patient assuming an upright position or with bleeding side down. And surprisingly, if you can get a history from the patient, they might be able to tell you where they feel the blood is coming from. They feel gurgling sensation, pressure sensation, a little discomfort in the upper lobe, the offending upper lobe. It's usually upper lobe disease, as I'm sure you're well aware. Oxygen therapy, of course, is always nice to consider, as well as cough suppressant. Control the systemic blood pressure, because it's usually from systemic vessels, so you'd want to eliminate any hypertension. An anxiolytic, because people get anxious when they start to cough up bright red blood. And antibiotic therapy, because of the possibility and probability, in fact, coexisting a bacterial infection, which is helping this event to propagate. Subsequent management then depends on how the patient evolves. Rigid bronchoscopy is always advocated as the best way of cleaning out the tracheobronchial, because you could put large or suction catheters in, or even rigid catheters in, to clean things out and really identify the bleed site. With the newer flexible fiber optic bronchoscopes with larger operating and working channels, flexible bronchoscopy is also an option, and I would individualize, and you can make that decision as you face each individual patient. You can consider photocatheter tamponade if you can find the lobar bronchus or even the segmental bronchus that appears to be the source of the bleeding. You can consider ice saline lavage, or in fact room temperature saline lavage, in order to clear and incite the cascade, the clot cascade, in that offending area. And you can consider topical epinephrine, thrombin, and fibrinogen. These all can work in selected cases as a temporizing procedure to prevent spillage into the contralateral lung or ipsilateral other lobe or lobes, because you don't want the patient to drown in their own blood, and so that you get then a hold of the situation, determine exactly where the blood is coming from, exactly what your subsequent management is going to be. Now, rigid bronchoscopy, as I mentioned, can be used to determine what site of bleeding, what the site of bleeding is. It's usually an upper lobe, and flexible bronchoscopy can also be used for this purpose. If the patient's already intubated, you may want to try at least to attempt to do this procedure using flexible bronchoscope, so you don't have to remove the endotracheal tube. For surgical management, a double lumen tube is preferable, or a single lumen tube with a bronchial blocker down the main bronchus of the lung that's bleeding. That's not as good as the double lumen, but it's another option. And the reason why I say it's not as good is that the Fogarty catheters use number 7 venous Fogarty embolectomy catheters. They're not designed to sit in a bronchus and obstruct it. They're designed to embolectomize clot in veins. And they are high pressure cuffs. They can herniate back into trachea with a little blood and a little surgical manipulation by yourselves as you're trying to mobilize that lung that's going to have adhesions because of the TB and so on and so forth. So it's not ideal. But often these things happen at night, and often your anesthesiologist will not be comfortable extubating a patient with a single lumen tube, reintubating with a double lumen tube if they don't do that on a sort of regular basis. So those options should be made available to them. Frequent suctioning to keep the airways clear. Whenever you're operating on a patient with a diagnosis of massive hemoptysis, even if it's temporarily controlled and the guy hasn't bled 2 or 3 days, you need to ask anesthesia to frequently look down both lumens of the ET tube to make sure there has been no bleeding incited by your surgical manipulation, and if there is, to lavage it clear in order to prevent contralateral aspiration and complications thereof. Lobectomy with coverage of stump is the usual operation that should be entertained. On the left side, stump coverage isn't always as necessary as on the right because of the long stump and the fact that the left upper lobe stump will bury itself into the mediastinum more readily than a right upper lobe stump. Contraindications to surgery, and if you suspect your patient who you're seeing in an ER setting fulfills one of these, then you would want to temporize and not rush that patient necessarily directly to the operating room. Bilateral advanced disease, if they're known to have bilateral coexisting terrible obstructive pulmonary disease with FEV1s in the 1 range and FVCs less than 40% of predicted, you might think that they're not an operable candidate from the get-go and think about alternatives to management. If you can't identify the bleeding site, you wouldn't know which lobe, because very often patients will have bilateral upper lobe disease. You might have a difficult time deciding which side to operate on, and you consider angiographic testing to see if you can delineate this a little better. If the patient is known to have coexisting carcinoma, either lung carcinoma or other carcinoma, either locally advanced or metastatic, you might not consider them for definitive surgical management. And if the patient refuses, as some patients do. So what do you do in terms of non-operative management to try to get the patient to survive this hospitalization? Well, bronchial artery embolization has become the mainstay. It is palliative in that rebleed rates are as high as 66% with time, but it is quite effective, in other words, about 90% initial control of hemorrhage. So it buys you some time. If there's been some contralateral aspiration with this event, you can embolize them, settle them down for a week or 10 days, get the aspiration cleared, clear any coexisting bacterial pneumonia, and then electively operate on that candidate. So initial non-operative management until they stabilize or optimize their status, and then operative management if they turn out to be suitable candidates for that. And here's a typical example of a patient with bilateral apical disease and horrible coexisting emphysema. I mean, I could show you this picture without the apices and you'd say, oh, the perfect candidate for lung volume reduction surgery. Well, this patient, here's a lateral view showing that there's quite a bit of scarring in the apex all the way from the major fissure up bilaterally. And this patient had an FEV1 of 0.8 and was not a candidate for surgery. This is a bronchial artery embolization series of 4 slides showing you a huge bronchial artery coming off the intercostal brachial and going up to the upper lobe. And then you'll see some serial pictures of coils, like you can see a coil in here going in, and more coils, and finally the final appearance with various coils being to obliterate flow to that territory. Okay, what about moving on now to bronchial fistula? That's usually associated with chronic empyema, and your surgical options are as follows. Now, this is a less common indication for surgery in patients with TB, but your surgical options would include a pleuropneumonectomy. In most people's hands, this carries a mortality rate of 20%. So this, and especially in patients over 60 years of age. So this would should be seriously considered before embarking upon. A stage procedure is often what's elected for, with LOS or flap drainage to try to clean up the space initially. Muscle flap closure of the bronchopleural fistula. Once the space is reasonably clean and you see evidence of granulation tissue. Further obliteration after closing the bronchopleural fistula with a muscle flap, use of other flaps to obliterate the residual space, and performance of, finally, as a third stage, a clag procedure, filling any residual space that you might have with antibiotic-containing solution and closing the skin and hoping for the best. Now, what about bronchial stenosis? This is a long-term complication of TB. It often is complicated by post-obstructive pneumonia, lung abscess, bronchiectasis, and a persistent productive cough. The surgical options include dilatation in this setting, though if the stenosis occurs beyond a lobar bronchus, the success of bronchial dilatation is limited because those orifices are quite small and will tend to restenose quite quickly after your procedure. Stenting, likewise, is very effective for tracheal stenosis and main stem bronchial stenosis. Even the right bronchus intermedius can accept a stent fairly readily, but smaller orifices than that, again, you run into difficulties with stent migration, coughing up stents, and stent obstruction because the size is too small. Sleeve bronchoplasty can also be entertained in order to reset the offending stenotic segment and re-anastomose relatively normal segments to one another. And finally, pulmonary resection. If the degree of bronchiectasis is so great that you have no hope of ever returning that area, that portion of lung to normal, pulmonary resection, segmentectomy would be a very difficult operation, but not impossible to do if it's just a segment that's the offending area, or lobectomy would be appropriate. What about trapped lung with residual space? Well, if it's acute, empyemectomy and decortication might be appropriate, whereas if it's chronic, and that's the more common scenario you're faced with, you drain the space and do the muscle flap thing once again. Thoracoplasty, it still has a role in selected patients who are so skinny, cachectic, that they don't have suitable muscle, or that have had previous thoracotomies that have not been of the muscle-sparing variety, or who don't have any omentum to swing up into the chest to help to obliterate space. So this is a technique which sort of fell by the wayside in the 70s and 80s, but that I know when I trained in England in the late 80s, we did probably 4 or 5 that year. Just a testament to the fact that it's probably something that you should still be aware about and have a few papers in your file on. Pleuropneumonectomy is reserved again for cases where the lung is largely destroyed. Again, just to emphasize that the mortality rate in most series reporting pleuropneumonectomy is quite high. Complications of plavage therapy, you may be familiar, you may have seen in your training your teachers showing you cases of leukocyte balls in the chest or paraffin wax in the chest, and these can extrude or become severely infected many years after, i.e. 20, 30 years after they have been placed, originally designed to obliterate this space, as collapse therapy was in vogue in the 40s and 50s for TB. Surgery to remove the foreign body and obliterate the residual space on an individualized basis, and I actually have one case of a lady who in 1953 had some paraffin placed into her left chest in the apex, and you can see that here's her residual cavity, a big rind right here, and the paraffin, instead of occupying this space, has migrated through the interspace into her subcutaneous tissues in the parascapular location. So we simply just removed this and opened this widely, cleaned it out, and filled it with antibiotic-containing solution, closed it, and she's been fine now for 18 months. I don't know if this is going to be long, but she's now 78 years old, and that was all that we thought was necessary at this time. She currently has no evidence of recurrent tuberculosis, and it had been many years after her initial treatment for it. Surgery for Mycobacterium other than TB, MOTT. The indications are identical to those that we've just gone over for tuberculosis itself. But surgery is required more often for these atypical mycobacterium because of the increased incidence of drug resistance. And so you will be called upon by your pulmonary colleagues to perform surgery for the same indications in these atypical mycobacterium settings in the future. Now, a little bit on fungus, and I've chosen to divide surgery for fungal disease, or to classify fungus under this heading, into the pathogenic fungi and the opportunistic fungi, and we'll treat them separately. As you know, histoplasmosis is a fungus that is endemic to the area of the Mississippi Valley. Coccidio is endemic to California, the West Coast, and blasto is southwest. And we'll talk about pathogenic fungi infecting immunocompetent hosts in endemic areas, because that's most commonly what occurs. The infection with histococcidio in immunocompetent hosts is usually self-limited and subclinical, and therefore would not come into your realm. Surgery, however, may be needed in some cases to confirm the diagnosis, if the case is a little atypical, or to rule out malignancy in patients who have, for example, a coexisting history of smoking, or to treat complications, which are fairly rare in these pathogenic fungus infections. The opportunistic fungi, as you might expect, and as I'm sure you're all aware and have treated on multiple occasions, infect either immunocompromised hosts or immunocompetent hosts with areas of destroyed lung from previous infection, whether it's bacterial or TB or what have you. Surgery in these cases is often needed either to confirm the diagnosis, what fungus, how to treat it, or to treat the complications of the infection. Now, treatment, just to go over again very briefly, amphotericin B is still considered to be the gold standard antifungal agent against which all the others are compared. It's certainly the most potent and has, as I'm sure you're all aware, many side effects. Pre-treatment with antipyretics and so on is almost the rule. Flucytosine, an antimetabolite, is very good for cryptococcal meningitis with amphotericin B. You need to have a double-pronged approach in this setting. And this is a common manifestation, unfortunately, in patients who are HIV-positive manifest AIDS. The azoles are nice because they can be given orally, and ketoconazole is for the pathogenic fungal infections if they need to be treated. Fluconazole for cryptococcal meningitis as maintenance therapy after initial treatment with flucytosine and amphotericin B. And itraconazole for those opportunistic fungal infections, as well as for the pathogenic ones, maintenance therapy in some cases. Now let's talk about coccidiomycosis briefly. About 60% of patients who have coccidiomycosis are asymptomatic. Among the 40% with symptoms, pulmonary manifestations are present in the vast majority and are associated with an abnormal chest X-ray. Among patients with AIDS, there's a 42% 6-month mortality rate associated with this otherwise a fairly benign and self-limited infection. So in a patient with AIDS, aggressive therapy is certainly indicated. Now, what is the abnormal radiological appearance? Well, coccidio affects the upper lobes in 70% of patients as a mass or multiple nodules or an infiltrate or infiltrates. In endemic areas, however, as many as 60% of the solitary pulmonary nodules that might be attributable to coccidio are found in 26 to 35% to actually be carcinomas. And so just because a patient is in an endemic area and has a solitary pulmonary nodule, it doesn't mean that it should be aggressively investigated to be certain that this is not a carcinoma. Certainly the minimum of a wedge resection is indicated in many persons to rule out carcinoma. So indications for surgery with coccidio to rule out carcinoma: if there's secondary infection in a coccidial cavity with aspergillus, if there is with complicated aspergillus, and just a simple aspergilloma within an old cocci cavity, rupture with pneumothorax, sorry for the typo there, hemoptysis, which is rarely massive, might be an indication, or patients who present with and are found over time to have an enlarging cavity might be candidates for surgical treatment. Here's an example, and I apologize, it's often difficult if you don't have a case of your own, getting it out of a book is often difficult, but there is a cavity here, I don't know if you can see it with this extra light, that resolves over time, just showing you the self-limited nature of this disease. This, on the other hand, and you probably can't see this, is a giant cavity which was felt to be at risk for pneumothorax and was resected. Now, cystoosmosis usually presents as hilar and mediastinal adenopathy with or without pulmonary infiltrates. 20% of patients develop a chronic form of histoplasmosis with a solitary pulmonary nodule which grows and calcifies, or chronic cavitary disease, or mediastinal granulomatous disease, or the unfortunate individuals that may go on to develop fibrosing mediastinitis and complications thereof. The indications for surgery in patients with histo, once again, in anyone in whom you feel you need to rule out coexisting carcinoma, to treat the broncholithiasis or bronchostenosis associated with migration of those mediastinal or hilar granulomas into the bronchial tree over time, and you'll find that does happen, and people will say they call up rocks because they're heavily calcified. For palliation of fibrosing mediastinitis, SVC replacement has been described. Pulmonary resection to treat pulmonary venous obstruction has been described. And bronchoplastic procedures have been described for the broncholithiasis, bronchostenosis scenario that can occur with histoplasmosis. Blastomycosis usually presents with an upper lobe infiltrate, though it may also present as a mass or multiple nodules. Amphotericin B is very effective in treating blastomycosis if the diagnosis is established. Surgery is reserved to establish the diagnosis if bronchoscopy or other means are unable to do so. And if it's a pulmonary nodule, for example, which may be fairly peripheral in its location, this may be required. About 20%, as I've indicated on this slide, of patients with blasto undergo a lung biopsy in order to establish the diagnosis. Not so in this case, where bronchoscopy was able to establish the diagnosis for what looks to me to be a carcinoma of the left hilum, but this was blastomycosis, and here you see it on CT. This is what blastomycosis looks like on bronchial biopsy. The very thick walls and the broad budding yeast forms that you see are characteristic. And getting now towards the most offensive organism and in the opportunistic category now, talking about Aspergillus infection. There is a classification of Aspergillus infection, a non-invasive bronchial allergic form versus invasive forms. And Aspergillomas are part of the invasive forms, and they may either be simple or complex. Hemoptysis is the presenting complaint in over 50% and as high as 80% of patients with Aspergillus infection. And here's an example of a simple Aspergilloma. And simple means there is a cavity with the halo sign that you see, the Aspergilloma within the cavity, and the lung around it, and this is a high-res FUNCAT CT, is largely normal in appearance. This is in contrast to this case of a complex Aspergilloma, where the lung around it, you can see just even on plain chest x-ray, is largely destroyed. The parenchyma here is largely destroyed. And although I don't know this patient personally, I suspect that this patient had been infected with TB, and this is a consequence of that infection. Secondarily is secondary infection of his tuberculous cavity with Aspergilloma and coexisting lung destruction partly from the TB. The non-invasive bronchial allergic form requires surgery only if bronchiectasis is complicated, and that's very rare. The invasive form requires surgery if you develop chronic cavitary disease associated with hemoptysis, and that's much more common. Aspergilloma accounts for about 65% of pulmonary Aspergillus infection. As I mentioned, it's simple if it's surrounded by normal parenchyma, complex if it's surrounded by chronically diseased lung. It affects the upper lobes or superior segments of the lower lobes in the vast majority of patients, and can be multiple in about up to 20% of patients in some reports. Indications for surgery in setting, we've mentioned most of them. Recurrent mild to moderate hemoptysis, massive hemoptysis, chronic symptomatic disease, a progressive infiltrate around a mycetoma, indicating a chronic infection, or a mass lesion of unknown etiology to rule out a coexisting carcinoma. The principles of surgery when dealing with this, when you know ahead of time that this is what you're dealing with, is to resect all disease, trying to conserve as much normal lung as possible. Consider once again coverage of the bronchial stump, and to avoid as much as possible post-resectional spaces by using pleural tents, muscle flap transposition, and even thoracoplasty on occasion to limit the risk of a post-operative empyema. This is an example of a resected Aspergilloma in a liver transplant patient. This is the lung, however, just to show you what it looks like grossly. And this is what those hyphae look like under the microscope. And second to last opportunistic organism that we're going to discuss is Cryptococcus, which, unlike the others that I've mentioned, affects the lower lobes preferentially. And that should be the key to making that diagnosis. Cavitation is rare cryptococcal disease. It's the first manifestation of AIDS in 45% of patients, cryptococcal disease. Amphotericin B is the mainstay of therapy, with surgery reserved to diagnose a pulmonary nodule or an infiltrate. And here's an example of an interesting patient who did not have AIDS, who was about 8 weeks postpartum. On her antepartum ultrasound, she was found to have a small renal cell carcinoma. By that I mean 2 centimeters. And about 6 weeks postpartum, she underwent a nephrectomy. They knew she had these little infiltrates in the lower lobes, limited to the left lower lobe, prior to her nephrectomy, but didn't think they looked like metastatic disease, and went on to just do her nephrectomy. And she had localized disease, no invasion of her capsule, and or fat, and no nodes. And she came to me when these appeared to progress over a period of about 6 more weeks. So she came to me about 6 weeks after nephrectomy. And this was cryptococcus. This was diagnosed by thoracoscopic wedge resection. And it's rarely reported associated with the immunocompromised state of pregnancy, but might have had something to do also with the immuno state of her, with also the coexisting carcinoma, even though it was a very limited one, 31-year-old woman. And here's another picture showing the diffuse nature. When we did her thoracoscopic wedge, her left lower lobe was completely involved. But interesting, her left upper lobe was completely spared. And this CT sort of corroborated the intraoperative findings. I actually extended one of her incisions to stick my hand in because I wanted to get a good feel for everything in the upper lobe to make sure there was nothing else going on. But we got it frozen, of course. We didn't get cryptococcus. We got granulomatous disease, and then it grew on culture. And the final fungus that we will discuss before breaking for a moment is mucormycosis, horrible fungus, which presents with hemoptysis quite commonly. And surgery is advocated early on in the treatment of this disease to patients who do not appear to be responding suitably to as little as 72 hours of amphotericin B therapy. Only if they have limited disease. Of course, if it's bilateral, affecting all lobes, you can't do very much for those patients. But this particular fungus has a propensity for rapid progression and dissemination. And in fact, that's highlighted by the fact the diagnosis is made ante-mortem in only 40% of patients. So in other words, we just don't suspect it enough. The mortality rate is 65% overall, with disease confined to the lung. And so it just attests to the severe nature of this infection if you catch it. And of course, patients who are HIV positive are at much higher risk than immunocompetent hosts. And in fact, to my knowledge, rarely reported in immunocompetent hosts. We'll stop there. I'd be happy to answer any questions you have with regard to this topic. Yes?
I'm sure you'll address this when we get into the thoracoscopic techniques, but that young girl with the renal cell carcinoma, I think one would consider metastasis very, very likely in that setting, and surgery for metastasis for that disease is quite good. And why would you do a thoracoscopic procedure in that situation when, if they were meant, you'd take them off?
Well, what we did was, first of all, she had her nephrectomy in Pennsylvania and then came to Chicago 6 weeks later. So the doctors in Pennsylvania didn't think, and I agree, when the CT appearance doesn't look like metastasis. It's more of an infiltrate than a rounded cannonball type metastasis, which is most commonly associated with renal cell. Now, they elect to do nothing with those lesions prior to her nephrectomy, and in retrospect, that was probably okay. My plan at the time of surgery was to wedge resect one of those lesions, get an intraoperative frozen section, which we did, and then proceed from there. And our differential did include metastatic disease, and the patient had also signed for thoracotomy and metastasectomy if that had been necessary. But fortunately for her, it wasn't. Can I?
50-year-old woman presents with 2-centimeter apical lesions bilaterally, and bronchoscopy and CT needle show atypical mycobacteria, but she refuses to take the medication, but will consent to surgery. Is there any role for surgery as the primary treatment for atypical mycobacteria?
Yes, because so often, as I mentioned, these MAIs or these atypical mycobacteria are resistant to therapy, and no matter what you do, you can't get rid of them. I guess it depends on how symptomatic she is, if she is symptomatic, and how infectious she might be. But you know, if you have bilateral disease, you have to remove it all, or there's no point. And so you're looking at either, depending on their location and what they look like and how competent you are, you're looking at a median sternotomy with bilateral apical wedge resections or what have you, or thoracoscopic procedures, and so that, you know, fairly extensive.
If she's asymptomatic, is there any hope that by doing surgery early you would prevent the progression of disease? Again, assuming that she won't take pre or post-operative medication.
Yeah, well, you know, patients like that are, of course, very difficult, and I would hope that they would be very rare. I think that you'd need to, the answer is probably yes, because if they're not going to comply with therapy, even therapy will probably only help 50%, that would probably be appropriate. But a period of observation, if they're not infectious, if they don't have positive sputum, a period of observation to see how the disease evolves itself might also be appropriate, depending on their risk and other coexisting problems. We don't see a lot of atypical TB yet, and though I've seen a lot of massive hemoptysis lately, we usually see about 2 cases a year. I've seen 2 cases in the last couple of months. One lady had to have a pneumonectomy. She had huge bullseye bilaterally taking up all of her apex, except for some old TB that was in both apexes. She also had sarcoidosis. She was also a former IV drug abuser in a methadone program. And she had a destroyed left lower lobe, which had been treated for 6 to 8 weeks prior to her admission with massive hemoptysis by a pulmonologist with antibiotics, with no improvement in the appearance of the lobe. And we embolized her acutely because she was so ill, and she had never had pulmonary function tests. And she stopped bleeding for 72 hours, and we got pulmonary function tests. Her FE1 was 0.8. And we didn't have time to get a VQ scan because she bled 48 hours after the initial embolization, 700 cc's between midnight one night and 7 a.m. So we figured, though, that her perfusion to her left lung was 0. And in fact, it was. We had to do a pneumonectomy. It took us 4 hours just to dissect the lung out. We had to do an intrapericardial pneumonectomy because you could not, for the sarcoid and the old TB and the coexisting infection and the aspergillus, even get to the hilum safely except from an intrapericardial route. And we knew that she would have a fairly frozen mediastinum because of all this coexisting disease. We left chest tubes in and covered her stump with a latissimus flap. We just spared the lattice and brought it over the stump. And assumed that she was going to have an empyema. We did not know at the time that she had aspergillus, but we suspected that she had definite contamination of the cavity because of the largely destroyed lower lobe. And we'd also see cavitary disease in that lobe as we're dissecting it, because of course things didn't come out just with normal visceral pleura all intact. And so a week after surgery, aspergillus was growing from her pleural fluid. She was feeling fine, and she had 2 chest tubes in draining. So we took her back and did a resection, just packed the whole thing, and it's granulating in beautifully. I mean, she's going to be another year with packing, and she realized that. But the cavity is actually pretty small because of the chronicity of the disease on the left side. She has very little in the way of a space. She doesn't have a huge post-pneumonectomy space. It's probably like more like a lobectomy size space because she had chronically shifted. Her heart was completely in left hemithorax. And she's, doing very well. And I suspect we're going to see more and more of these kinds of cases as time goes on. Any other questions? Yes?
In your written section under aspergillus infection, you say surgical principles are resection of all these that conserve all normal lung tissue. Are you saying you should not do a lobectomy for aspergillus?
In selected cases, you might not need to do that, and in patients with very compromised pulmonary function, if it appears that there are segments of that lobe that are not affected, that's probably correct. Most common operation would be a lobectomy, however. Okay, let's go on to the next talk. And in the next hour, we're going to cover everything you need to know about mediastinal tumors, which, of course, is impossible to do, but we'll just try. Well, this is just a very chest radiograph lateral view just to show you what I'm going to use as the boundaries for the mediastinum. As you know, some people say that there's a superior, anterior, middle, and posterior mediastinum. I group the anterior and superior compartments together with the middle and posterior because the lesions in the anterior and superior compartments are identical. With mediastinal tumors, as I'm sure you're well aware, signs and symptoms depend on the location and the, let's see if we can fix it a bit, and the size of the lesion, on whether or not it's benign or malignant, on the presence or absence of infection in the lesion, and on whether or not they elaborate endocrine or other biochemical products, as well as the presence or absence of associated diseases. And I'll show you a slide on diseases associated with myasthenia in a few minutes. About 2/3 produce symptoms in children, whereas only 1/3 symptoms in adults, and that's probably related to the fact that the mediastinum is smaller in kids, and so a mass doesn't have to grow quite to the side it does in an adult before it causes symptoms. Most tumors have a predilection for a particular mediastinal compartment, with the exception of mesenchymal tumors, which can occur in any compartment. Tumor incidence and type are different in children compared to adults, and you'll see that on the next slide. And I think my handout's fairly complete with regard to these issues here. In adults, now this is based on just over 2,000 patients in 9 series. This is a cumulative slide. Neurogenic tumors and thymomas or thymic cysts are 1-2. Obviously, a place like a cancer institute, lymphoma might have more relative to a general hospital, which would have more this kind of distribution. You can see lymphoma is third, this particular group, with germ cell tumors running closely behind, then foregut cysts and pericardial cysts, as well as sort of other miscellaneous tumors. In children, neurogenic tumors in almost every series you'll look at will be top on the list. And this is based on just under 600 patients in 9 series, with foregut cysts being second, and that's something to be concerned with, because in kids, the foregut cysts will cause symptoms and are recognized much younger. Rarely in adults will you find a foregut cyst, although it's been known to occur. Cell tumors in children and lymphomas are third and fourth, with various and sundry other tumors, with thymic tumors way down on the list by comparison with adults. Now, if it's benign or malignant, how do you figure that out? Well, overall, the incidence of malignancy is higher in children. The percentage of tumors which are malignant in the anterior compartment, less than 40% malignant in adults. Of course, 20 to 30% of thymomas are considered to be invasive or malignant, all of lymphomas, and 15 to 20% of germ cell tumors in adults. Germ cell tumors are rarely malignant in children. They're almost always benign teratomas, and we'll go over that in more detail in a few slides. Once again, all of the lymphomas are malignant, and overall, 45% of anterior mediastinal tumors in children are malignant. In the posterior mediastinum, it's a little different. Only 1 to 3% of posterior mediastinal tumors in adults are malignant. They're neurogenic, as they are in kids, but in kids, over 60% of those tumors are malignant. And here's a histogram showing the age distribution of malignant tumors in the mediastinum. And you can see that in the very young age group, 0 to 10, only 27% are malignant. This rises through age 40 and then declines once again, except in the very elderly patients over 70, you'll find that almost 70% of the mediastinal tumors are malignant again. Lymphoma making up the majority in this spectrum. Just to know that there are many serum and urine markers which help to establish diagnosis of a particular mediastinal mass. And we'll go over the germ cell markers in more detail later on. But just to let you know that there are many markers which have helped greatly to establish different etiologies of masses in the mediastinum, as well as many immunohistochemical markers to narrow down the diagnosis. And I think, let's see if we can. And I don't know that you have to know every single one of these markers, but just to know that serum, urine, and immunohistochemical markers have all helped to establish the diagnosis of the etiology of mediastinal masses over the last few decades. Now, in the anterior compartment, you'll find 50 to 60% of all mediastinal tumors in all, and I'm really focusing now on adults. And as we mentioned in the previous slide, thymoma, lymphoma, and the germ cell tumors, with others falling as less common. And the relative frequency, approximately 47% are thymic, 23% are lymphoma, 15% germ cell, and 16% endocrine. This is based on 5 reports totaling 702 adults. This is anterior mediastinum now. Thymomas are classified, or thymic tumors are classified as follows: thymoma, epithelial or spindle cell variant, lymphocytic variant or mixed variant, thymic carcinoma, which can be of squamous or lymphoepithelial varieties, and the neuroendocrine tumors of the thymus, thymic carcinoid, and small cell carcinoma of the thymus. Thymoma represents 20% of anterior mediastinal masses in adults, and the histology is as indicated on this slide, most being mixed histology. Associated syndromes are common, with myasthenia being the most common, and is present in about 15% of thymoma patients. 50% of thymomas are asymptomatic in adults, and the workup usually includes a chest x-ray when it's discovered incidentally because it's symptomatic half the time, and is usually followed by a chest CT scan to further understand where exactly the mass is and its limits. Other testing is dictated by symptoms, and a biopsy is appropriate only when the diagnosis is in doubt. Not to overwhelm you, and this slide, of course, will not focus very well either, but these are all of the symptoms associated that have been described in association with thymoma. And just to let you know, there are several neuromuscular syndromes, hematologic syndromes, immune deficiency syndromes, Bollinger diseases and autoimmune disorders, dermatologic diseases, endocrine disorders, renal diseases, bone disorders, malignancies associated with thymoma. And so there are myriad, and you would want to direct your history and physical to determine whether or not any of these coexist in an individual patient. This is an example of a patient with an asymptomatic thymoma that was discovered at the time of her emergency room presentation in Virginia, having been shot by her husband earlier that evening. Then she turned around, shot him, and killed him. But anyway, this was the... I love that story. This was her thymoma, it turned out. Of course, you wouldn't know that that was the diagnosis based on the PA chest x-ray. Here's the lateral film, and that really doesn't give you much information either in this particular case because it silhouettes the heart border. But here's the thymoma on a CT scan. And here's the thymoma having been excised. And we'll go into why this was a wrong operation in a little while. And if I don't mention it, ask me the question later. This is an example of a thymoma which is more fibrous than the one you just saw. And thymomas are characterized by their fibrous septi and lobules, lobulation. These are the immunohistochemical features associated with thymoma. Cytokeratin marker is positive in a large number of them, as are epithelial membrane antigen and LU7. Again, I don't think that this is vital information for you to know on a board exam. However, just to let you know that there have been some study into it, and there are many markers which will be positive and help to figure out exactly what type of thymoma you've got versus other mediastinal tumor. Staging, Masuoka developed this staging system. Stage 1, completely encapsulated thymoma with no evidence of capsular invasion on microscopy. Stage 2, invasion into the surrounding fatty tissue at the time of surgery, or the mediastinal pleura, or the capsule on histology. Stage 3, invasion into neighboring structures like the pericardium, the great vessels, innominate vein being most common among those, or the lung itself. Stage 4A are thymomas which have either pleural metastasis or pericardial metastasis. And stage 4B are those which are associated with lymphogenous or hematogenous metastasis to lung most commonly, liver most commonly. And here are a series of groups of several series of thymomas indicating that they are stage 1 in almost 60%, stage 2 or 3 in 37%, and stage 4 in A or B in a minority of cases. So you're almost always dealing with stage 1, and the next slide will go into treatment options, therefore, with thymoma. Surgery should include either a median sternotomy, a sternothoracotomy, or a right thoracotomy, again, depending on where your lesion is on CT, with removal of all anterior mediastinal tissue. As you recall that slide of the thymoma that in the woman with the gunshot wound, that was just the thymoma itself. There was no other tissue or very little mediastinal tissue. The rest of the thymus was not removed in her. That was done thoracoscopically, and that's the wrong approach. You notice that thoracoscopy is not indicated here as one of the appropriate approaches because all of the thymus should be removed. I do not doubt that there are a small number of surgeons in the United States that can do a complete thymectomy using a bilateral thoracoscopic approach. But I think that the majority of us, and the answer on the test is to pick one of these depending on CT appearance and get all of the anterior mediastinal tissue from the thymus, from the root of the neck, down to the diaphragmatic surface. Complete removal of all invasive disease as much as you can. Debulking if major viscera are invaded. And for local recurrence or palliation, surgery is also indicated. This is one of the few thoracic surgical tumors for which debulking is advocated. And I actually had occasion to do one just over Christmas. The first time I've ever done this, a patient who was 36 years old, had myasthenia, and grossly invasive thymoma that we knew from the get-go we wouldn't be able to completely resect.